Hi, and welcome back to our series on the Thai health system. In this video, we're going to look at the health financing in Thailand. Throughout this video, we'll look at the history of health financing in Thailand and how it led to the major health reforms of 2001. We'll look at the details of Thailand's 3 health financing schemes that collectively provide universal coverage, and the implications of payment mechanisms and other features on the health system. Let's start by looking at some of the indicators for health financing. In Thailand, the current health expenditures, which is the sum of all annual spending on health, equates to about 635 international dollars in purchasing power parity, or PPP. Without getting too technical in economic terms, the idea here in using international dollars in PPP is to use a common currency based on relative cost of items between countries, assuming that there is a single true price for all goods. So for example, if a computer costs $1,000 in the US, but that same computer costs 30,000 baht in Thailand, then we can assume that 30 baht is the same as $1 US and use that. In reality, we do that for a whole set of goods, not just that one computer, and that's how we can compare health costs in different currencies in equal terms. And it allows us to make equal comparisons across countries. When we compare Thailand's numbers to the US, Japan, and Australia, all more developed and high-income countries, we see that Thailand spends much less on healthcare. We also see that relative to the country's GDP, which is the sum of all economic activity in the country, it's a relatively small amount, only 3.7%. These two numbers tell us that Thailand is more frugal or efficient in healthcare costs than the US, Japan, or Australia. The overall spending in total dollars and in percentage of GDP more resemble that of developing countries. Another thing we can look at is where the money is coming from. 3 major sources of spending in a health system are general domestic budget, out-of-pocket spending, and voluntary health insurance. What we see is that in this regard, Thailand more resembles a developed countries. Thailand's figures are fairly comparable to the US, Japan, and Australia, which are 3 highly developed economies, with around 80% of health expenditures shouldered by the government, and around 10 to 15% out of pocket. So this will be the question we'll try to answer in today's video. What is Thailand doing to have this paradoxical situation in which their overall spending resembles a developing country, but their financial protection resembles an upper-income country? Before we do that, though, I'd like us to quickly compare Thailand's spending status with other regional peers in Southeast Asia. And let's look first at total spending. Thailand spends more on healthcare than many other Southeast Asian countries. But they're less than the average here with the dotted line. Again, highlighting the relative efficiency of the system. If we look at the share of spending that's out of pocket compared to government spending as a percentage of GDP, we see that normally, as overall healthcare expenditure increases, which is usually related to economic development, we see that the out-of-pocket spending decreases. This is sort of the average here with the red dotted line. And we can even break this graph into quadrants, where you have health spending as a percentage of GDP greater than and less than 5%, and as well as out-of-pocket spending that's greater than or less than 20% of total expenditures. So in the upper left or lower right quadrants, we might consider this sort of normal conditions where most countries lie. Either with the less developed and the more developed economies, generally speaking. But this upper right quadrant is a bad place to be. It means high spending, but still mostly out of pocket. On the other hand, this lower left quadrant would be a good place to be. Low overall spending and very little out of pocket. And that's where we see Thailand, within that lower left quadrant. So by all accounts, Thailand is in a relatively unusual position with regards to its health financing. It's hailed as one of the best examples of universal health coverage and health financing in the world. So what's the secret? Well, the first thing we have to realize is that the Thai government has had consistent dedication to prioritizing government spending on healthcare. This figure here is reported in inflation-adjusted dollars, so the increase that's shown here is the annual increases on healthcare have outpaced inflation since the year 2000. And throughout that time, it's been the government that has annually increased its commitment to the health system, allowing for out-of-pocket spending to continually decrease. At the same time, a robust private healthcare and health insurance market has been maintained, allowing an alternative to the public healthcare system. We see that private prepaid health insurance has actually increased, reflecting the economic development and the increased purchasing power of many Thai people in the growing middle and upper class. As you can see in this graph, the year 2001 was a turning point with regards to health financing. Many people attribute the success of Thailand's health financing system to the popular Prime Minister of Thailand, Thaksin, who governed from 2001 to 2006 in that role, and he won a landslide victory, he and his party, in 2001. And they're right to attribute these successes to him and his party, since Thaksin and his party campaigned on a platform of universal healthcare access with a small co-payment of 30 baht per visit, an amount that's roughly equal to a US dollar. This campaign promise earned the resulting program the nickname of the 30 baht scheme, which people still use to this day, despite the fact that the 30 baht co-payment no longer exists, and we'll talk about that later. But it's important to understand that a lot of important things have happened prior to 2001 that made it a perfect storm of events and allowed for the implementation of those reforms in 2001. And importantly for health financing, Thailand had gained a lot of experience experimenting with many forms of health financing prior to 2001. The road to universal health coverage began in 1975 with the introduction of the low-income card. By 1981, the Ministry of Public Health had issued 10.9 million low-income citizens a card that allowed them to receive free or highly subsidized health care at public health facilities. Throughout the years, the program was expanded to include other vulnerable groups, including the elderly in 1992, children and disabled in 1993, and veterans in 1994. And at that point, the program was renamed the Medical Welfare Scheme for the underprivileged. The Low-Income Card Scheme, or Medical Welfare Scheme, produced many valuable lessons that helped shape the major reforms of health financing and the introduction of universal health coverage in 2001. One thing they learned is that it's hard to get people enrolled. While the application for the card was free and had relatively simple criteria, the voluntary nature of the program resulted in incomplete coverage of the targeted poor population. Approximately 89% of the eligible low-income group and 64% of the total eligible population held cards in 1998. Thus, despite nearly 25 years of effort, many of the targeted groups were still not receiving the benefits of the program. And furthermore, some cardholders avoided using the card due to its stigma. Others reported discrimination and reduced service at healthcare facilities due to hospitals' reluctance to serve low-income patients. On the other hand, the program also suffered from leakage of ineligible non-poor populations into the program. Households often underreported financial assets to meet the eligibility criterion. By comparing census data, for example, it was estimated that around half, or 45%, of cardholders were actually above the poverty line and likely to be ineligible for the program. In both the case of the undercoverage and of leakage, the weakness of the scheme's means testing for income resulted from difficulties in estimating income. In Thailand, the informal employment sector has comprised and still comprises a significant portion of the Thai population. Seasonal work such as agriculture and informal work such as street vending and household labor make it difficult to estimate income. So the experience showed that using income as a qualifier for healthcare coverage was difficult with the informal economy of Thailand. Finally, in addition to learning how to enroll people, many lessons were learned about how to purchase healthcare services or make payments to the healthcare providers, and to do it equitably. In the early years, the low-income card formula was based on healthcare utilization and on population. So densely populated central region, which had good access to healthcare, would have high utilization, so it received a disproportionately better amount of funding, while leaving the north and the northeast regions, which had actually the highest proportions of the poor population, being severely underfunded. Therefore, it was learned that the healthcare utilization or demand-side funding was not an equitable way to allocate funding to the healthcare delivery system. Now, at the same time in the 1980s, Thailand was also trying to expand coverage to other target populations. Of course, the formal sector workers had compulsory social health insurance program that began in 1990, and we'll talk about that later since that still exists now. And the civil servants had their benefits beginning in 1978. And we talked about the underprivileged groups. There was still a significant part of the population that still had no viable way to get financial coverage for health services outside of expensive private health insurance. And that really wasn't viable outside of Bangkok at that time. So in 1983, the Thai government began piloting a voluntary community-based health insurance program. The idea was that households would pay in a small annual premium, starting at that time around 500 baht, and that would be pooled and organized locally. That's the idea of community-based health insurance. The program struggled, though, at first, and it did eventually grow as the national government began to provide risk pooling equalization fund and as well as subsidies. Much like the low-income scheme, the voluntary health card scheme provided several valuable lessons for the 2001 when universal health coverage was implemented. First, they learned that adverse selection is a real risk, particularly following the Asian financial crisis of 1997 and 1998. They found that people waited to enroll until they were sick. And so this was another indication that voluntary systems were not effective at achieving universal coverage. Secondly, they learned about cost reimbursement models. For example, reimbursing hospitals with a fee-for-service model led to high costs. Therefore, they would take the experience of the health card scheme and use it to improve cost control measures. And thirdly, they learned the importance of risk pooling. Local, community-based health insurance risk pools were vulnerable. Therefore, sustainability could best be achieved if the risk was pooled across a large population. So, to quickly recap, there was a long march starting in 1975 and culminating in 2001 to achieve universal health coverage. What's also remarkable was that Thailand did that at the relatively low development status of less than $2,000 GDP per capita, and only a few years in the wake of the devastating financial crisis of the late 90s. So let's talk about the three schemes that provide health coverage to the Thai population today. First is the Civil Servant Medical Benefit Scheme. This is for the government employees, and it's a fringe benefit. It was established in 1978. Second, we have the Social Security Scheme. This is for formal workers in the private sector. It's a form of compulsory social health insurance, and it was established in 1990. And third is the Universal Health Coverage Scheme. It's an entitlement for all people, and it's the default coverage if you don't qualify for the first two. It was established with the reforms of 2001. Each scheme is financed from a different funding source and managed by a different organization. So here we can follow the flow of funds with these arrows, and we can see the key management organizations for the three schemes here. So I'll point out a couple things that are important here. The Civil Servant Medical Benefit Scheme and the Universal Coverage Scheme derive all of their funding from the central government budget. Taxes are collected, and the legislature allocates budget annually. In the case of civil servants, the Ministry of Finance is the purchaser. They make payments to the providers. In the case of UCS, the purchaser is the National Health Security Office, or NHSO. Social Security also receives budget allocated from the central government, but that only makes up a portion of their funding. Primarily, the Social Security scheme is funded by payroll deductions, which are automatically deducted from employee salaries and matched by the employer. The other thing to note is that the reimbursement models for each scheme differ, and we'll go into those details later. Let's focus on the civil servant scheme first. I want to point out two important details here. First, the specific department of the Ministry of Finance that's responsible for managing the scheme is called the Comptroller General's Department. Secondly, I want to point out that for each scheme, they are only reimbursing for health care services. In the case of public hospitals, which, as you know, dominate the healthcare delivery market in Thailand, the Ministry of Public Health pays the salaries and the operational budgets of the hospitals. And this concept is known as a purchaser-provider split. The civil servant scheme is eligible for government officers, including into retirement, as well as their dependents. Overall, it covers roughly 5 million beneficiaries, and it's the smallest of the three. As a fringe benefit, it has one of the most permissive terms for services. Beneficiaries have wide discretion to choose where they receive their services, and they have access to a wider set of health services and medicines compared to the other two schemes. Importantly, outpatient services are reimbursed fee for service. Therefore, one of the biggest issues with this scheme is the ballooning costs of outpatient services, as hospitals bill for expensive imported and brand name medicines. As you can see, the fee-for-service model has prevented any ability for cost containment. In addition, any attempts to reform this model have been resisted, as it's quite lucrative for hospitals. Switching to the Social Security Fund, we see the so-called tripartite funding. That is, equal contributions from the employees, the employers, and the government. Covering roughly 10 million, the Social Security scheme is the second largest one in Thailand. It's eligible for private employees. If an employee works at a private company, they should automatically be enrolled by the employer into the system and have contributions deducted from their paycheck. For big companies, this is no problem, but for small companies, there are sometimes issues. And there have even been cases where employers don't actually send in the paperwork and register their employees into the system and falsely deduct the money from employee paychecks without registering into the system, although this is relatively rare. Social Security uses capitation, which pretty equally balances the financial risk between purchaser and provider. Because of this, as well as the fact that the Social Security scheme tends to cover healthy working age population, Social Security is the most financially sustainable and stable scheme of the three. Finally, we come to UCS. Here we see that the NHSO is the purchaser. The Universal Coverage Scheme covers the largest number of Thais, roughly 49 million. It's a comprehensive package that covers nearly all major services. In the case of UCS, the payment model is solidly based on the lessons learned from prior attempts that we talked about earlier. First, there's automatic enrollment. So if you're not eligible for civil servant or Social Security, you're automatically part of UCS. And secondly, the payment mechanisms are geared towards cost containment. They use a combination of global budget, capitation, and diagnostic related group, or DRGs. And the UCS approach, which uses closed-ended provider payments, radically changed hospital budgets in 2001. Prior to UCS, most operating budgets and resources were allocated to health facilities through the Provincial Health Office, and they were based on utilization rates and number of beds, like I mentioned. Unfortunately, these figures could be easily influenced by politicians and result in corrupt budgets. Under UCS, however, the outpatient budget is allocated based on an age-adjusted capitation and the total number of UCS members in the locality with some adjustments. For inpatient services, a global budget is calculated that they'll spend overall, and for each of the 13 public health regions, an inpatient expenditure is reimbursed based on the cost weight of the DRG. The reason that a global budget is necessary to constrain total inpatient spending is because DRGs alone can be manipulated by pushing patients into a higher cost DRG, which is a concept referred to as DRG creep, for example, by adding extra procedures or comorbidities. It's a way of gaming the system. By capping a global budget, it reduces this incentive to overbill and contains the cost for the government. Another reason why a closed-ended approach to provider payments helps to control costs is that it minimizes the risk of supply-side moral hazard. Medical providers have no financial incentive to induce unnecessary demand, which they would have with a fee-for-service payment method. On the contrary, because providers have a financial incentive to minimize costs, it's actually a concern with the UCS system that there could be under-provision of services. So the NHSO must remain vigilant with regular monitoring and audits to protect against this possibility. When we consider the three dimensions of universal health coverage according to the WHO model, we see that on the x-axis, Thailand is well covered. Virtually the entire population has had coverage since 2002. On the y-axis, we see that a high proportion of the costs are covered. The system doesn't rely on deductibles, on co-payments, or other fees. Almost all services in any scheme is free at the point of service. And it's for that reason that out-of-pocket spending remains small at 12%. And in fact, this number mostly reflects elective costs for people that voluntarily choose to access the private healthcare system. And finally, when we look on the z-axis, we see that the benefits packages are very comprehensive. Major surgeries, antiretroviral, and many other expensive services are all covered in all three schemes. The impact of Thailand's health financing is measurable. Catastrophic health expenditures have dropped to affect only 1% of the population, with both the richest and the poorest quintiles seeing improvements. Health impoverishment has also greatly reduced. It's estimated that perhaps 80 households per 1,000 have avoided medical impoverishment as a direct result of the implementation of universal health coverage. So in conclusion, Thailand has used nearly 3 decades of experience to shape its health financing reforms that it implemented in 2001. And it's used that to produce an efficient and equitable system built on 3 schemes that achieves universal coverage that's comparable to wealthy countries, but at the spending level of a developing country. It's been nearly 20 years, though, since those reforms, and Thailand faces many pressures demographically, politically, and economically. We'll look at some of those challenges in a later video. That's it for this video. Please check out other videos in the series on the Thai health system.